Okay, let's unpack this. You know that feeling, that relentless dull ache, like a vice tightening around your head.
Yeah, I think most people do, unfortunately.
Chances are you've tangled with a tension headache. You're incredibly common, but knowing the specifics, not just how they feel, but what causes them, who gets them, and crucially, how to manage them is absolutely vital, especially if you're navigating something like the MSRA exam.
Exactly. It's bread and butter stuff, but the details matter.
So today we're doing a deep dive into exactly that, tension headaches, our source material, a focused set of high-yield MSRA revision notes.
Right, straight from the revision material.
Our mission is to take these notes and translate them into a clear, digestible breakdown. We want to pull out the most important insights, solidify those core concepts, and help them stick for you, turning study points into genuine understanding.
Making it practical, yeah.
We'll move through the topic systematically, covering everything from the basic definition to the tricky bits like, say, differential diagnosis and management strategies.
The whole picture.
Think of this as joining us to walk through those revision notes together, highlighting and discussing the absolute most important information.
Sounds good. Where should we start?
Let's dive right in with the fundamentals. What is a tension headache?
Okay. So fundamentally, it's classified as a primary headache.
Meaning the headache is the condition, not a symptom of something else.
Precisely.
Yeah.
Not secondary to another underlying illness. And our source notes highlight it's actually the most prevalent primary headache out there. Very common.
And that pain, how's it typically described?
It's usually that dull, aching pressure. Often people say it feels like a tight band or a cap wrapping around the head.
Right, that classic description.
Yeah. And a really key feature, the notes point out, is that tension headaches usually lack neurological symptoms.
Okay, so no flashing lights, no numbness or weakness, typically?
Generally, no.
Right.
And that's a big differentiator we'll definitely come back to when we talk about telling it apart from other headaches, like migraines.
Makes sense.
The notes also break down tension headaches based on frequency. You've got episodic.
Which is less than 15 headache days a month.
Correct. And then chronic, which is defined as 15 or more headache days a month for at least 3 months running.
And I imagine the chronic type has a much bigger impact on daily life.
Oh, definitely. Much more disabling.
It gets confused with migraines so often, doesn't
Yeah,
it?
it really does. Which is exactly why our source emphasizes that getting the diagnosis right hinges almost entirely on taking a really thorough history from the patient.
So it's not just about the pain itself, but the whole story.
Absolutely, the whole picture.
Mm-hmm.
And underpinning it all, the notes mention its multifactorial nature.
Meaning?
Well, both physical and psychological factors are usually at play. It's not just one thing.
Okay.
And understanding that multifactorial aspect right from the definition stage is really the first step in truly differentiating it from other headache types you might be considering.
Got it. So if that's what it is, the next logical question is why it happens. The notes delve into the etiology, the causes.
Right. And a crucial point the notes make right at the start is acknowledging that the exact, precise cause isn't fully understood.
Ah, okay. Not completely pinned down yet.
Not entirely, but the notes list several contributing factors that seem pretty clear based on what we know. Think about physical tension, particularly in the muscles of the head, neck, and shoulders.
Right, that muscular tension. You can often feel it.
Exactly. And that often links directly back to psychological factors like emotional stress and anxiety, which are big contributors mentioned in the notes.
Okay, stress and anxiety definitely ring true.
Poor posture also makes the list.
Which makes sense if you're straining those neck and shoulder muscles all day.
Totally. And habits like jaw clenching or teeth grinding, bruxism, medically speaking.
Bruxism.
Sleep disturbances are mentioned as well. So
Yep.
it really drives home this idea that it's not usually one single thing, but likely a mix of physical and psychological issues coming together.
A combination.
Yeah. And the notes reinforce that connecting these potential causes to the patient's symptoms is why taking that thorough history is so essential. It helps make an accurate diagnosis and plan effective treatment.
So you can sort of trace it back. Maybe stress leads to jaw clenching, which causes muscle tension.
Exactly. It can be like a chain reaction. Understanding those potential links is key.
Okay. Building on the causes, the notes help us figure out who might be more susceptible by listing specific risk factors. This sounds like high-yield stuff for exams.
Definitely. Knowing risk factors helps you anticipate and advise patients. Our source lists female gender.
Okay.
Having a family history of tension headaches, high stress levels, and existing anxiety or depression, those are pretty major ones.
Seems logical, tying back to the causes.
It does. Add to that list. Poor posture, engaging in prolonged activities that strain the neck and shoulder muscles like, long hours at a computer.
Very common these days.
Yeah. Incredibly common. Also, lack of physical activity, chronic sleep disturbances, and even the use or withdrawal of certain substances like caffeine or alcohol.
Right, so identifying these factors is a key part of piecing together the diagnostic puzzle.
Exactly.
Now, pathophysiology, how it actually works at a biological level. You said the cause isn't fully understood.
Correct. And again, the notes preface this section by saying the pathophysiology isn't fully understood either, but they outline the prevailing theories.
What are those theories?
Well, they involve things like increased muscle tension, yes, but also potential changes in brain chemicals, specifically mentioning serotonin.
Ah, serotonin, okay.
There's also the idea that pain-sensitive structures in the head and neck, think nerves, muscles, might be activated or just become more sensitive than usual.
More sensitive to pain signals.
Yeah,
Okay.
exactly. And the notes mention alterations in how pain is actually perceived by the brain, including something called central sensitization.
Actual sensitization,
Yeah.
like the nervous system's volume knob getting turned up.
That's a great analogy, actually. Over time, the system becomes hypersensitive to pain signals. What's interesting, and something the notes point out, is that there might be an overlap in these underlying mechanisms between tension headaches and migraines.
Okay, so it's not always clear-cut boundaries.
It seems not entirely. While the pathophysiology is complex, having a grasp of these potential pathways helps explain why the symptoms feel the way they do, and importantly, why certain treatments might target these areas.
Right, it links back to management. Okay, this next section feels crucial for both exams and just, well, clinical practice. Differential diagnosis.
Absolutely critical. What else could this headache possibly be? You need to rule out other things.
So what conditions does our source list that can mimic tension headaches?
The main ones listed are migraine headaches, cluster headaches, sinus headaches, and headaches that actually originate from the neck. Those are called cervicogenic headaches.
Okay, quite a list.
Yeah. And this is where those characteristic features we talked about earlier become your diagnostic tools. You have to compare and contrast.
So thinking about that bilateral, non-pulsatile, band-like pain,
Right.
how does that help?
Well, it helps you rule things out. For instance, that pattern is different from a typically unilateral throbbing migraine, or the excruciating unilateral pain of a cluster headache, or the facial pain and pressure you might get with a sinus headache, or pain specifically triggered by neck movement in a cervicogenic headache.
So keeping those distinguishing features front of mind is key for differentiation.
Precisely. It's all about the pattern recognition based on the history.
Okay, let's shift gears slightly and look at the epidemiology, focusing on the UK as per the notes. What's the big takeaway here?
The headline is, tension-type headache is the most common primary headache disorder you'll encounter in the UK. Full stop.
Wow, the most common. That really puts it into perspective.
It really does. The notes give lifetime prevalence estimates that range quite widely, actually from 30% up to maybe 78%.
That's a huge range.
It is. The annual incidence is estimated somewhere between 14 and 44 cases per 1,000 person years.
And who gets it most often?
Prevalence tends to peak in individuals aged 20 to 39 years, and the notes indicate it's slightly more common in females than males.
Okay. Knowing these stats just helps manage expectations for everyone involved.
Yeah, knowing how common it is helpful context.
Bringing it back to the person experiencing it, let's talk clinical presentation, how these headaches actually look and feel day to day.
Right. So the notes reinforce those key features we started with. The pain is typically dull, bilateral both sides, and described as pressure or tightness, like that band. There might also be tenderness if you press on the neck or scalp muscles. Pericranial tenderness, it's called.
Okay. Now, you mentioned key absences earlier that help distinguish it.
Yes, absolutely critical. According to the notes, the pain is not typically worsened by routine physical activity, climbing stairs, walking around, unlike a migraine often is.
That's a big one.
Huge. And significantly, there's usually no nausea or vomiting associated with it. Maybe some mild phonophobia or photophobia, but not usually both, and not the severe kind seen in migraine.
No nausea or vomiting. Got it.
Duration varies, can last hours to days. And the notes emphasize there's usually no functional limitation. Someone with a tension headache can generally still go about their day, maybe uncomfortably, but they're not usually completely wiped out like someone with a severe migraine might be.
Right. They can function, albeit perhaps poorly.
Pretty much. It's common in teenagers and adults, presenting as either that episodic type or the chronic type we mentioned.
And what about triggers? things that set it off.
The notes list, the typical ones you should ask about. Stress is a big one, tiredness, dehydration, missed meals, inactivity, and again, poor posture.
Sounds familiar.
Yeah, the usual suspects for many people. And for diagnosis, the notes provide specific criteria stating these features should be present in at least 10 previous headaches for a firm diagnosis.
Oh, okay, so there's a checklist.
Essentially, yes. It helps formalize it based on the source. Number 1, bilateral mild to moderate pain.
Okay.
2, frontal occipital location, so felt in the front and or back of the head.
Front and back.
3, non-pulsatile quality, not throbbing.
Not throbbing.
And 4, crucially, not worsened by routine activity.
That seems like a really solid checklist to run through.
It is. The notes specifically contrast this with migraines again, noting migraines often have a more gradual onset, variable duration, can feel constant, but are generally less severe than severe migraines and might respond to over-the-counter meds in their episodic form.
Okay.
So diagnosis is fundamentally clinical. That history is absolutely paramount for differentiation. A physical exam is mainly done just to rule out other causes, make sure there's nothing else going on.
So bottom line. When you're thinking tension headache, mentally run through that checklist. Bilateral, mild mod, frontal occipital, non-pulsatile, not worse with activity.
That's the core of it, yes.
All right, investigations. This seems like it might be a straightforward section based on what you said.
It is, but it's really important. The notes state clearly. Diagnosis is based on symptoms and medical history, full stop. Investigations are rarely needed for typical tension headache.
Okay, rarely needed, but that begs the question, when do you need to investigate further?
Now that's where the notes highlight the red flags. These are the signals that tell you this might not be a simple tension headache and you absolutely need to look deeper. This is very high-yield stuff.
Red flags. Got it. What are they?
Okay, think about headaches with a sudden explosive onset, like a thunderclap headache. Or extreme severity, the worst headache someone's ever had.
Okay, sudden or severe.
Also, if the headache is associated with other concerning symptoms like confusion, neck stiffness, photophobia, that light sensitivity, fever, nausea, or vomiting.
They'll sound more serious.
They absolutely can be. Also on the critical list, any history of recent significant head trauma or the presence of new neurological deficits, things like weakness in a limb, sensory changes, slurred speech.
Neurological signs are definitely a warning.
Big warning signs. These are the alarms going off, indicating you need to rule out more serious secondary causes like bleeds or infections or tumors.
So just to be crystal clear, for a typical presentation,
For a typical tension headache meeting those criteria we discussed, the notes are very clear. No routine tests are needed, no blood tests, no routine imaging. Additional tests, like a neurological exam or imaging, perhaps an MRI or CT scan, are only considered if you suspect a secondary cause, often prompted by spotting one or more of those red flags.
Right. And what about things like neck x-rays or eye tests? People often ask about those.
Good question. The notes explicitly mention that routine cervical spine x-rays and eye tests are rarely helpful in the diagnosis of tension headaches themselves. They might be needed for other reasons, but not usually for the headache itself.
So overall, unless those red flags are waving, investigations usually add very little to the picture for tension headache.
That's the key message, yes. Focus on the history and the red flags.
Okay, let's move on to management. How do we actually help someone with these headaches?
Right. The notes describe management as a comprehensive approach. It needs to be tailored based on how severe and how frequent the headaches are, and it often involves combining multiple strategies. It's not usually just one thing.
Makes sense. How is it broken down?
It's broken down into several key areas. First up, lifestyle modifications.
The non-medication stuff.
Exactly. Helping the patient identify and avoid their personal triggers, maybe by keeping a headache diary. That's often really helpful.
Yeah, I can see that.
Also, stress management techniques, things like relaxation exercises, mindfulness, encouraging regular gentle exercise, advising on good posture, especially if that's a trigger, and ensuring they get regular restful sleep. Foundational stuff, really.
Okay, lifestyle first, then presumably medications.
Yes. For episodic tension headaches, the less frequent ones, the notes point towards simple over-the-counter pain relievers. Paracetamol is usually first choice, or NSAIDs, like ibuprofen.
Standard painkillers.
Pretty much. But for chronic tension headaches, those happening more often, the notes suggest prescription medications may need to be considered.
Such as?
Well, they mention muscle relaxants as an option, but more commonly, low-dose tricyclic antidepressants. Specifically, amitriptyline is mentioned as the one often considered.
Amitriptyline. Okay. Often used for chronic pain.
Exactly. At doses lower than typically used for depression, psychological interventions are also listed as important.
Like CBT.
Yes, cognitive behavioral therapy, particularly helpful for managing stress and anxiety triggers, and also relaxation techniques like deep breathing or meditation.
Makes sense, linking back to the stress component.
Absolutely. Our source also lists acupuncture under alternative therapies as potentially helpful for some people.
Interesting. What about behavioral things?
Behavioral interventions include things like physiotherapy, especially useful if there are clear posture issues or muscle imbalances in the neck and shoulders. And the headache diary is mentioned again here. It's both diagnostic and a behavioral tool.
That diary seems really central.
It can be incredibly powerful and foundational to all of this management. The notes stress patient education.
Just explaining things clearly.
Yes. Providing a clear diagnosis, explaining the nature of tension headaches, often reassuring people it's not something more sinister, and addressing their concerns and questions, that builds trust and adherence to the plan.
Definitely. Now, any specific prescribing details from NESIC guidance mentioned? That's usually key for exams.
Yes, the notes pull out some specifics, likely via NESIS, first-line acute treatment, typically paracetamol or ibuprofen, as we said.
Okay.
Codeine is mentioned as a possible option if the others are ineffective, but, and this is a but the notes specifically state it's not routinely recommended.
No.
Because of the significant risk of causing medication-induced headaches or medication overuse headaches, rebound headaches.
The headache caused by the painkiller itself.
Precisely, a really important complication to avoid. For chronic TT, low-dose amitriptyline is the medication specifically noted for consideration as a preventative.
Amitriptyline for chronic prevention. Got it.
And importantly, the notes advise explicitly avoiding opioids like codeine and dihydrocodeine in chronic cases, largely because of that medication overuse risk and lack of good evidence.
Right. So this management section really translates that knowledge into practical patient care decisions.
It does. It's about having a toolkit of options.
Okay, nearly there. Prognosis. What can someone expect long term?
The notes clearly differentiate between the episodic and chronic forms here.
How so?
Well, for episodic tension headaches, the prognosis is generally favorable. They often resolve on their own, tend to decrease in frequency and intensity over time, and cause minimal long-term disability.
That's reassuring.
It is.
Wow.
Chronic tension headaches, however, are different. They carry increased morbidity, meaning more illness burden, and significantly impact quality of life. The transformation from the episodic to the chronic form is highlighted as a noteworthy and less favorable development.
So chronic is a bigger challenge.
Definitely. And a critical point emphasized for prevention, which relates directly to prognosis, is avoiding the prolonged use of analgesics or triptans. The notes define this as using them on more than about 15-17 days a month.
Why?
Precisely to prevent those medication-induced headaches we just talked about. Getting into that cycle makes the prognosis much worse.
So the takeaway is, most tension headaches are manageable and improve, especially episodic ones, but the chronic forms pose a bigger challenge and carry risks, including from the treatment itself if not careful.
That sums it up well, yes.
Which leads us neatly to the final section, complications.
Right. And the good news highlighted in the notes first is that tension headaches typically do not lead to serious medical complications in themselves. They're not usually dangerous in that sense.
Okay, that's important reassurance.
It is. The main impacts, particularly with chronic TT, are really on a person's quality of life, their productivity at work or home, and causing significant psychological distress like anxiety or low mood.
So the impact is more on living well.
Exactly. The notes also mention that without appropriate management, episodic headaches can indeed become recurrent and potentially transform into the chronic type. That's a complication in itself.
The progression to chronic.
Yes. And probably the most significant complication, often stemming from the management rather than the headache itself, is medication overuse headache. Those rebound headaches from using acute pain relievers too frequently.
So we're back to that again. It seems really crucial.
It's a major pitfall. It highlights how the management strategy itself needs careful handling to avoid causing its own complication.
Wow. Okay. So we've taken a pretty comprehensive deep dive into the world of tension headaches, guided by these high-yield MSRA revision notes.
We've covered a lot of ground.
Yeah, from the defining characteristics and potential causes to recognizing those crucial red flags, understanding the evidence-based management strategies, and knowing what to expect long-term with prognosis and complications.
Hopefully breaking it down helps it stick.
Absolutely. Breaking down the information this way, focusing on the key differentiators, the checklists like for diagnosis, and the why it matters. Hopefully that helps make these concepts more memorable and high yield for your revision and just your clinical thinking.
Applying the knowledge.
And maybe a final thought to leave you with, based on the source material. Given that even a condition as common as a tension headache isn't fully understood in its pathophysiology, as the notes kept reminding us, and it overlaps with other complex conditions like migraines, what does that tell us about the limits of our current medical knowledge?
That's a deep question.
And maybe about the ongoing, absolutely fundamental importance of taking a really good clinical history and empowering patients through education. Just something to think about as you apply this knowledge.
Very true. The basics remain paramount.
Well, thank you for joining us for this deep dive.
My pleasure.
If you found this structured approach helpful for breaking down complex medical topics for revision, you might find more resources like this. Do check out passthemsra.com and freemsra.com.
Great resources there.
Keep learning, keep questioning, and keep tackling those complex topics.